Dr. Kilbourne. We have been looking into the matter of other conference rooms and so far have been unsuccessful. The move also to the Annenberg building, as far as the Department of Medicine is concerned, is also going to be delayed. So that while we had hoped to be there in the spring, we probably will not be there at least until the summer. Now, maybe some of us will be fortunate enough to be on vacation at the time the move occurs or something like that. But I also found out that one of the casualties of economy and in order to make the space bank, one of the casualties was the major Department of Medicine conference room. So we will be the only department without a big conference room. However, there is going to be a conference room, a building conference room, which will hold 150 people on the 20th floor. We will be on the 23rd floor, so that is not too bad. Now, we will have a library, a small library conference room type of thing. I'm not sure how many people it will hold. It may be enough for the group. We will have to find out as we try things. That will be on the 23rd floor.
There's a library conference room on the 24th floor that's currently in what's designated as Space Bank.
Right, that was supposed to have been our big conference room.
And it can't be freed up in Space Bank.
No. That is not our space. That space belongs to the school. And so we have no call on that space. We'll still be working on trying to move out of here. We will, on December 12th, switch from this room to the Guggenheim Hall in 5 East 98th Street for the first Gutman Memorial Lecture, and Dr. Weingarten will be giving that lecture on gout, and that will be at 2 o'clock. Now, we will, if we can get this room at 2 o'clock, from then on, all noon conferences will be, all grand rounds and such activities will be at 2 o'clock instead of noon, and we will move the Moore Conference probably to 12:30. We should know by next week whether that move is a permanent one or not. Depending on the availability of this place. Anybody else have any items of interest they may want to bring up for conversation, discussion?
One of the problems that is for the 2 o'clock meeting, there are a group of people who were trapped, for example, in the outbreak of the clinic. They have raised the concern about 2 o'clock. I think the 2 o'clock amendment is a good compromise, but it may be important either to move that clinic earlier so they can start earlier, or move it later so they can start later.
Okay. Well, there was an alternative suggestion that Dr. Spillman made, and that is we move the conference to 3 o'clock, in which case we could have the 13th floor Annenberg room. There is, that takes care of the clinic, because then the clinic physicians can spend their hour in the clinic and leave. I have no really strong feeling about this. For the practicing physician, 3 o'clock would obviously be better than 2 o'clock, and 2 o'clock is better than noon.
Well, almost everybody comes for two, I mean, on the round, because your round starts.
Right. Well, they're only the ones that are on service at that time, but I think everybody
The
would.
block conference is a great time.
I think it's a reasonably
Great
good time.
conference. Now, if you only adjust the clinic conference.
That we could
clinic,
do.
session.
That we could.
Would 3 be as good?
What's that?
It would be better. And it would be just as good for the people who come and sit. So, is there any objection to 3 o'clock? I mean, then instead.
If it is 3 o'clock, we cannot use the Guggenheim Hall.
No, I'm not talking about for Dr. Weingarten's lecture. That's fixed. That's fixed. They were not going to change that. The notices are all out and everything, so that we're not going to change. No, this would be after.
So when would more conference would still be at 12:30?
Yeah.
So then you could have like an hour of attending rounds, or if you wanted to.
We should overdo it.
Well, the way it is now is that they have attending rounds after with more time.
We do that now.
Yeah. So you just switch it to.
Well, all right. Maybe we'll see. I'll talk to Dr. Spillman some more.
We still ask the clinic to move its session, start a half an hour earlier or 3/4 of an hour earlier for the Wednesday group. I mean, that's an accommodation for the few in the medical clinic and the specialty clinics, and it wouldn't be an overburden. As a matter of fact, it might improve the traffic flow. So patients don't all jam up at the same time.
Well, they're going to be running by appointments anyway. That whole thing is changing, hopefully changing with computer-oriented appointments or something.
Are they going to be examining the patients also by appointment?
I don't know. We may be in for a severe disaster over there when we move in. That remains to be seen. Anyway, I'll talk to Dr. Spillman about what the feasibility of 3 o'clock in the 13th floor.
You know, the 13th floor, the elevators, only one elevator that runs up there.
Very good.
There are no buttons at all.
They run on their own schedule, like at Mount Sinai. Four runs an hour, 15 minutes each, you know, like Long Island Railroad.
They're not much better in this building.
No, I'm saying, but every elevator at Mount Sinai develops its personality.
All negative.
Good old bad.
Well, we shall see. I've also just heard that the AOA lecture in January on the 24th is going to be Dr. Louis Weinstein. That too will probably be in Guggenheim Hall, I guess. No, that's the 12th floor Annenberg you got for that one. Okay. Who's talking next week?
Dr. Levin is talking this week
On?
on a graphic look at the national.
And are we going to have a meeting in Christmas week? Between Christmas and New Year's?
Yeah, that's the CDC. On your desk.
Okay. All right.
With respect to Dr. Weingarten, that you be here that Wednesday morning, so that we try to conduct some rounds with Dr. Weingarten, with the medical students and house staff throughout the morning period.
Okay.
Can we get a schedule so that the house staff and medical students will know possibly when to be around?
You wanna
Yes, we'll work on that.
take charge of it? Between Dr. Ribner and Dr. Briggs, you will have liaison. Also, we're trying to arrange for a departmental Christmas party. I don't know what the status of. Josie, do you know anything about the status of that?
No, we thought we'd have it on the 20th or so.
Annual.
If you want to be non-denominational.
that in lieu of the New Year's party?
As far as I remember, the New Year's party was a hospital function, and I think that's been given up. It wasn't the last couple of years it didn't exist. I don't know of any plans to resurrect that thing. But this would be strictly a departmental cocktail party. Yeah, we're recording. All of this is coming down for posterity. Dr. Kilbourne is going to talk to us a little bit short of breath on influenza. Dr. Kilbourne is the professor and chairman of Department of Microbiology.
Thank you, and needless to say, a lot of apologies. When things don't get on my calendar, they don't get on my calendar, as you can see. I have it on for December 5th. I'll be glad to come back again. How much time do we have? Cut off at 1 o'clock?
Yeah, 2 minutes after.
Okay. Well, I have lots of things to say and lots of slides, and practically no organization of my thoughts at the moment, so forgive me. Influenza is a unique infection. It's the only infection that I know of, certainly of man, in which the infectious agent is capable of mutating so extensively that the virus can circumvent pre-existing immunity. The only possible exceptions to this are trypanosomiasis, where there's a little bit of evidence that there may be antigenic variation occurring during the course of illness, which may lead to relapse. Some evidence with Borrelia recurrentis, or relapsing fever, that this may be the case, but the evidence is rather tenuous. So we have basically a problem in molecular variation genetic level. And what I'd like to try to do in the next few minutes is to try to tie this in with the nuances and vagaries of the disease as we see it. Now, this rounds is very timely because just this morning I had a call from the Bureau of Biologics, and who are in control of flu vaccine regulation, among other biologicals. And they wish to set up a meeting, actually the week after next, to consider the possibility of yet another change in vaccine formula. Now, we can add this to the lamentable confusion of the present about why you're giving 2 doses and so forth. But in fact, this represents information from the Far East that yet another strain change in the Hong Kong variant has occurred, which is of the same magnitude as the change which we found with the England 42, which occurred in 1970 or 72, compared to the original variant. Let me begin at the beginning of my story with the first slide, please. Well, the first point I'd like to make is that influenza as a term has 2 meanings. One is the strict scientific meaning in which it defines a very specific disease caused by a specific virus or group of viruses. And in the broader generic sense in clinical practice, it comes to refer to any combination of symptoms of a febrile illness and respiratory tract involvement. And for this reason, the disease is not reportable, despite its enormous importance economically and otherwise. Have the next slide, please. Now, really, the whole story of influenza is on this one slide. The basic problem is this, that in recent years, in about every decade, there has been a major mutation of the virus with respect to the antigenic nature of its external proteins, the proteins with which it encounters the environment, and the environment being man's respiratory tract and antibody. And when this variation occurs, and this antigenically novel virus is introduced as a kind of Andromeda strain in a universally pan-susceptible population, different from measles or polio because regardless of whether one is 50 or one is 5, one will have little or no antibodies to it. But in this situation, a pandemic occurs. And in present-day modern life, this is the only infectious agent that causes pandemics, in a sense of a global saturation of the world's population with the infectious agent within a couple of years, and consequently an enormous impact in terms of high morbidity in a brief period of time. So the impact of influenza is double. The impact economically is in terms of the high morbidity. The secondary impact, which is the one we're most concerned of in vaccination, is the impact on mortality. The secondary bacterial pneumonia is the usual cause. Now, after this period of saturation, which takes a couple of years usually, this represents 1 year of this pandemic exhibition of the virus, there is a briefly endemic persistence of the virus in the population, and then there are cycles which are roughly biennial in occurrence during the rest of the decade, and during this time we see a progressive decline in the extensiveness of the epidemics and to some extent in the clinical severity of the individual case, although this is less evident than the epidemiologic suppression of the disease. And coincident with this, we can show by serologic examination of the population an increase in specific antibodies to this new agent. At the end of roughly a decade, the intervals recently have been 1957, 1968. We're now in sort of the middle period of a decade. We see a situation where the population antibody level is high against the agent, and when the agent is less easy to detect in patients or in the population, either on the basis of evidences of serologic conversion, looking for the virus as it occurs in pneumonia patients, or in terms of the clinical exhibition of the disease. And it is at this point where apparently there's some kind of a vacuum established, an ecologic niche, if you will, when in the immediate past there has been the introduction of yet another agent, which we could call A3 or A4 or whatever, which again will be very different in its coat proteins from the original infecting virus. Now, the reasons for this are complicated, and we'll get back to those in a minute. But this is essentially the problem. Now, the point I would also stress is that during this period of a decade, the virus has not been holding still, but in fact, the strain recovered, we'll say, 3 years after the introduction, can be shown to be antigenically somewhat different than the original strain. So we have two kinds of antigenic variations that are proceeding. The first kind is a kind of stepwise progressive point mutation that we associate with drug resistance, resistance to bacterial drugs with bacteria, and this is of relatively minor degree, and I might say parenthetically that the necessity for frequent vaccine change during this period of, say, the prevalence of the Hong Kong type is open to question. That is, these differences can be shown, but their actual significance in terms of compromising immunity is quite borderline. But then at the end of the decade, the kind of antigenic change that occurs is a profound one, and as one would expect, as shown by the lack of population immunity. And this obviously requires, in prophylactic terms, the creation of then a new vaccine which will match the new strain. Next slide, please. Now, a look at the recent past history of influenza, in terms of this present century anyway, suggests that we have had pandemics in 1918, the introduction of a antigenically new strain somewhere in this period, probably about 1929, and then the other recognized pandemics after 1918 were 1947, 57, and 1968. These are the periods of the introduction of antigenically novel virus which swept the globe. Now, I've also tried to introduce here in this slide, which is a little complicated, the newer nomenclature of the viruses, which recognizes the fact that there's not one surface protein, but two that vary independently and are antigenically different. These are the hemagglutinin and neuraminidase antigens, respectively. We'll say a little bit more about these later. And consequently, this terminology has arisen. I think the significance I might point out to you of it is that if one examines these older strains with the newer techniques, one can show that whereas the hemagglutinin antigen, H, was subject to considerable variation during the time after 1918, the neuraminidase antigen, as the minor antigen of the virus, was subject to less variation, and hence the common designation of N1. So that H2N2 refers to the hemagglutinin, the neuraminidase of what we used to call the Asian strain, which is prevalent in the 1957-68 period. We're now in the period of H3N2 or Hong Kong subtype prevalence. Anything you hear about England strain or 42 or whatever is simply another Hong Kong variant. We are in the Hong Kong decade right now. Next slide, please. Now, this is a highly schematic representation of the virus, and it does illustrate some of the newer information that we have, which is important. But, of course, it is an enveloped virus, meaning that it is formed by budding directly from the plasma membrane of the cell. And like all viruses, including the myxoviruses, of which this is an example, or the recently christened toga viruses, used to be called arboviruses, these are, as you would expect, they are disrupted by organic solvents which interact with the lipid covering which is acquired from the host. So that the outside of the particle would be represented on the very exterior by two virus-coded proteins, where I've sort of cartoonized the way they look. But the hemagglutinin spikes are apparently represented to a greater extent on the surface of the virion. The mushroom-shaped things are the neuraminidase spikes. The hemagglutinin protein is the protein which is responsible for the binding of the virus to the cell. It is also responsible for raising the antibody which will be neutralizing to the particle. The neuraminidase is an interesting protein. Neuraminidases, of course, are widely distributed in nature, including in mammalian cells and in many bacterial species. The neuraminidase here is specific for the virus, is a virus-coded antigen under the control of the viral genome, and is a minor antigen. It is probably important in releasing the virus from the cell as the particle buds off from the plasma membrane. Now, recent knowledge shows that within, just inside these two proteins, is a lipid bilayer which is derived from the host. This is not coded for indirectly by the virus genome, but represents host material. And there's also a carbohydrate polysaccharide moiety in here, not shown, which is antigenic, but again is host determined. And within this is the major protein of the virus, which is delimits the core. This is known as the internal membrane matrix, or M protein. This is a small molecular weight protein of about 25,000. The heart of the virus, of course, represents its genetic material, which is distributed actually in a segmented form. The RNA, which is genetic material, occurs in 5 to 7 discrete segments. We're not quite clear whether these are linked in any fashion within the virus itself. This has considerable importance with reference to the possibility of genetic interaction between strains, or recombination, because these 7 nuclear protein fragments can be apparently randomly reassorted within the cell that is doubly infected with the virus. This provides a uniquely high recombination rate, which makes it possible to do some unusual things genetically with the virus, and also makes the virus able to do these things in nature quite readily. So much for the basic particle. You really cannot understand influenza without understanding the nature of its genome and the nature of its external proteins. The next slide, please. In gorgeous Technicolor, we have a representation of the various subtypes that have prevailed. The point that I emphasized inadequately with the first slide is the fact that not only is influenza remarkable in the appearance of a brand new strain from time to time, but when this happens, it completely supersedes the pre-existing strain, which apparently disappears from the face of the earth. So the remarkable thing to me is not so much that the virus, that something new appears, but that the old one is completely gone. So that we have these to examine only because we have deep freezers. And although we have the prototypes then of 1957 and even 1918 in terms of the swine virus, these are things which are just in the laboratory at the present time. And I've tried to show that there's an independent variation of the hemagglutinin and the mushroom-shaped neuraminidase molecules with time. There apparently are different selective forces operating against them. Now, the main thing I wish to show you here, which has been the source of some confusion in the literature and probably still is the fact that what happened between 1957 and 1968 was a complete change in the hemagglutinin, which is rather badly represented here as being green as opposed to blue, whereas there was no change in the neuraminidase. So this represented then a complete change in one protein with little, if any, change in the other. And it tells us that pandemics can occur with the mutation of only one of these two proteins. And for this reason, I believe, although I can't substantiate this completely, the impact of 68 was milder than what we've seen in 1957, because the population had raised antibody to the neuraminidase, although it could not deal with the virus with this completely changed hemagglutinin. So I think that the epidemic of 1968, or the pandemic, was damped by the pre-existence of anti-neuraminidase antibody. Next slide, please. Well, this is really more of the same, in which I've indicated that if one can judge pandemic severity crudely, that we can rank things as saying that we, of course, have no information about the antecedent virus in 1918, so we don't know the extent of the change in that situation. We can guess that it was considerable. And in the intervening time, there were these mutational changes in the absence of a pandemic at this point, although our records are not terribly good from that period. The worst pandemic of modern times is the one that we saw in 1957, in which there was considerable associated mortality, as many of you know. And then and that was associated with change in both antigens. As I said, I believe that the rather moderate nature of the 68 pandemic was predicated on change in only one protein. Next slide, please. And the other point I'd like to make is that the kind of variation that we're talking about, at least that we can prove and recognize, is a variation in antigenicity. Now, this is not to be equated with variation in the intrinsic virulence of the virus, because I'm unable to find any good evidence in the literature that would satisfy me that the virus, even of 1918, was intrinsically more virulent in man than the viruses that have come along subsequently. Now, it's not easy to prove virulence because it's always a reciprocal of host susceptibility. But if we look at the uncomplicated picture of influenza, this happens to have been in 1957, as a brief, usually 3-day fever. This picture is perfectly typical and characteristic from 1889 to 1918, 1968, all the way through. Flu now is what flu always has been as far as the clinical records will show. But on the other hand, the case fatality rate is a variable and is an important variable. And we can go into reasons for that. The next slide, please. That in patients that have underlying cardiopulmonary disease, specifically rheumatic heart disease, and still more specifically mitral stenosis, influenza is a notorious killer, and this is, I think, most dramatically brought out in the period of modern study in 1957. And so this actually represents what must be the same virus that we've seen on the previous slide, causing a 3-day illness, operating in a patient with underlying cardiac disease who died, and died in this instance of a primary influenza virus pneumonia uncomplicated by secondary bacterial pneumonia. Ones that we recognize have to do with the antigenicity. Next slide, please. Well, I'm making the point again that if you line up the symptomatology, you make a clinical profile of 1947, 1957, this being a relatively mild year and this being a severe, that the average case looks really no different. Next slide, please. Well, this goes back to the point I was trying to make on one of the initial slides, and that is what is happening during the period of prevalence of a given subtype. And I've simply tried to show that the selection that goes on is the reciprocal of the antibody that the host raises. That when a new agent is introduced into the population, in a pandemic introduction, that it creates, I'm afraid it doesn't show too well here, this is supposed to be pink, but the pink people here represent those who have had the experience with this pink virus here. That the virus to survive, because it's an intimate obligate parasite of man and has no other place to go, except, as I shall qualify later, must mutate. Now, it's constantly mutating, but it must be selected for. So that then, during this interpandemic period, we have a series of sequential changes which will affect the external proteins of the virus, particularly hemagglutinin. And similarly, we will have a changing phenotype of the population in terms of the antibody that is carrying around. With every burst of disease and epidemic during this period, we're going to have the raising of a new crop of qualitatively different antibodies to these changing antigenic determinants. Next slide, please. Now, these are peptide maps of tryptic digests of the isolated hemagglutinin of influenza virus. What is their significance? I think their significance is profound. These are not our data, but those of Graham Laver in Australia. And what he has done, and I think you can see it easily from the back row, he has examined the Asian strain, or A2 strain, and the Hong Kong strain with respect to the mapping and hence indirectly the amino acid sequencing of the hemagglutinin proteins, the changeable proteins. Now, these are two A2 strains. These would represent the pink and the red and the white variants within the period I just showed you on the previous slide. Minor antigenic changes. With these minor antigenic changes, the maps look virtually identical. If you look terribly closely, you can find a peptide here or there which is changed in its map distribution. I think you'd all agree that this and this are two quite different proteins, and it's very difficult to see how with even one or two sequential mutations you would go from this to this. So this is sort of a reaffirmation of the immunologic evidence of strain difference, which is quite important in terms of our considering whence come the new strains. Certainly it seems most unlikely that they can come by a series of mutational steps from one year to the next to arrive at such different proteins. Next slide, please. Well, this is simply, these are gel electropherograms of the RNA of the virus to show that the RNAs are different molecular weight and are separate. Next slide. Okay, now we get to a consideration of perhaps how some of these changes occur. It is very easy in the laboratory to take two very different strains of influenza virus and to doubly infect a cell system and to come out with progeny genomes which differ from either or both parents. And schematically represented is the fact that we're introducing two segmented viral genomes which apparently can randomly reassort, not completely randomly, but reassort within the cell so that you get the following redistribution of the parental genes. Now, there's some confusion, considerable confusion, and some of it was reiterated in the provocative article in Science of a couple of weeks ago about how we shouldn't mess around with influenza recombination because we'll create the virus in 1918. There's a misunderstanding about the potential of this. This kind of reassortment does not create new antigens, because if the hemagglutinin antigen is coded for by, we'll say, this fourth green RNA, and these are reassorted allelically within the cell, what you come out with is certainly different viruses. These are recombinant hybrid viruses which are different. But one has not changed. It is not possible. We've tried to change the character of the antigenic determinants in this fashion. What one can do, perhaps, with this, I could go on, please. Next slide. What one can do very readily is to segregate out the genes for these various proteins, and this has proved to be enormously useful in segregating, we'll say, the neuraminidase and hemagglutinin antigens so that one can raise specific antibody to one or the other of these two proteins. You can appreciate that having segregated the antigens out in this fashion, that antiserum then raised against this recombinant would turn out to be specific for this neuraminidase and specific for this hemagglutinin. This has been a considerable advance. Next slide, please. I wonder if time is going to permit me to get into this. Let me just briefly make this point. The nature of the two antigens is an interesting one in terms of immunologic response to them and the implications for the disease. What we see here are plaques of influenza virus unneutralized by specific antibody. What we see here is the same system, but in the presence of antibodies specific for the hemagglutinin or major protein antigen of the external coat. Complete neutralization of the virus. Here we see a phenomenon apparently unique for neuraminidase-containing viruses, as far as we can see, and probably for influenza viruses. And that is, in the presence of anti-neuraminidase antiserum, we get not neutralization of virus in the classical sense,
but rather we get a suppression of the evolution of the size of the plaque. Now, the importance of this goes beyond tissue culture because we have since shown that the same thing happens in mice, the same thing happens in man. That anti-neuraminidase antibody does not prevent infection but will suppress it, so that one can achieve an immunizing effect of this partially restricted infection and let the definitive immunization be carried out by the infecting challenge virus. Next slide, please. The presumed structural basis for this different kind of reactivity is only presumed. It could be on the basis of if divalent antibody binding is necessary for the neutralization to occur, the steric representation of the proteins on the virion surface might be, and there's some indication that they are, so separate in terms of neuraminidase antigen that an antibody molecule cannot make this divalent linkage to that particular protein. It could, however, aggregate particles by extending between virus particles. Or indeed, it could influence the enzymatic activity directly and inhibit release from cells. Let's see the next slide. Well, I think we'll have the lights, because I really don't have time to go into the other part. In closing, I could just say that we've speculated about the origin of pandemics, and I can give you the speculation verbally a little more readily than I can by showing the remaining slides. If the slides will help, we can come back to them if time permits. But in essence, the theory has been that since recombination occurs readily in the laboratory, that perhaps it can occur readily in nature. And that if it does, it could provide a mechanism by which the human strains might, as a rare event, enter the lower animals, which also have influenza A viruses. And these include specifically swine, horse, and numerous domestic birds. That in that setting, there could be a recombination, which would perhaps combine those genes necessary for the replication of the virus in man and picking up the new antigens, new in quotes, present in the animal species, and translocate them into man at a time when he had this ecologic niche after his own virus was at the end of the disappearance curve at the end of the decade. That's a very hurried, capsulized summary of the idea. I'm sure you want me to say something about the practicalities of immunization and so forth, and I'd be happy to do so if time permits that.
And would you also say a word about influenza B? Because apparently there's been some kind of mutation in that thing too this year.
Yep. The ABCs of influenza are that we have influenza A, influenza B, and influenza C. Now, these are in contradistinct. Everything I've said so far has been about influenza A. This is a major pathogen. It's the only one that's been involved in pandemics. It's the only one that infects animal species or is carried in animal species. This is principally what we're talking about. Now, in addition to that, and completely antigenically discrete, with no crossover whatsoever, but with the same biological characteristics and producing the same kind of clinical picture, is influenza B. Influenza C is a sometime thing which is probably important mainly in children as a rather minor respiratory infection, and you can really sort of exclude that from practical consideration right now. B has importance because although it's mainly a disease of high school students apparently, or older children, it can infect older people, it can induce pneumonia, it can indeed kill people on rare occasions. It is not subject to the frequency of antigenic variation that one sees with influenza A. Consequently, we do not recognize any subtypes as we do here. We recognize here the subtypes I indicated that they show N1, H1N1, H2N2, H3, and 2. These are all the variants I've been talking about. No, there have been differences observed, but not sufficient to justify different subtype designations. This year, or this past year, has been an exception to something called B Hong Kong 572. Now this reared its head in the Far East. The same little man who's making viruses in an alley in Hong Kong apparently is making B strains too, releasing them. So the confusing thing here is that this Hong Kong designation has nothing whatsoever to do with what we've been talking about over here. The strain designation simply reflects the site it happened to be isolated in, reflects where laboratories are. So you'll see a lot of England strains because the WHO reference center is there. You'll see lots of New York strains because of work done here and so forth. So it's misleading. It did first appear there. Now the point about it is, however, that it does seem to be radically different from the B strain now represented in the bivalent vaccine, which, as you know, has both A and B. Why the two injections? Well, these are the practicalities of life. At a meeting at the Bureau of Biologics last spring, we learned that the pharmaceutical manufacturers would be unable to incorporate this new B variant into the bivalent, readily available commercial vaccine. They had already made their batch lots and pooled the A and B, the obsolete B. So, the exigencies of life being what they are, the recommendation was still necessary for the immunization of high-risk groups and so forth. So the recommendation which was made, which has been unfortunately terribly confusing, is that the bivalent dose should be given because it contains the A that you want, but in order to get the B that you really want, maybe, because it hasn't appeared yet, one would have to give a supplemental injection of this separate strain. So this is what all the hoorah is about. And I think I would strongly urge anyone who has cardiac or pulmonary cases under their care to give the two injections, because there is always a possibility that this may create disease. The reading at the present time is that this winter, this strain seems to have taken over in England, and that the only bee that they have seen there has been of this so-called Hong Kong 5 type. Now, to confuse things a little more, and I don't want to, there was a period where some transitional strains, which were intermediate between this strain and the old bee strains, were found in England and Western Europe. And it wasn't really clear which way the cat was going to jump for a while, and this is one reason, I think, for the tardy recommendations about what strain was incorporated in the vaccine. But we have this terrible problem of mutability, which is unique. With a poliovirus vaccine, you can get a good vaccine, and then you turn it over to industry, and they make it, and that's it. But the other point, of course, is the vaccine has a bad name. And it has a bad name for many reasons. It has grown in chick embryos. It has been heavily contaminated with bacterial endotoxins in the past, and a lot of the reactogenicity is clearly on that basis, although the virus has some intrinsic toxicity. In addition to that, the antigenic potency has been low. There was a period when the standards for potency were not high. And coupled with that, if you give the wrong vaccine in the presence of the right epidemic, you're not going to get substantial protection. So that for all these reasons, the vaccine has come to have a bad name. It is actually a highly effective vaccine, even in its present form, except for the brevity of the immunity. It's somewhat like 75 to 90% protection will be given by the current doses of vaccine. And the current preparations are purified by either zonal centrifugation or by different chromatographic procedures. So they represent relatively pure preparations, and you may have noticed less reactogenicity in recent years.
Anybody else have any questions? If not, thank you very much for this.
I don't know, it's involved in